Hi, I'm Tamara, and this is TELUS Talks with Tamara Taggart. Hi, everyone. We have a returning guest today. Super excited to welcome Dr. Dominik Nowak back to the program. He is a family physician and health systems strategist. Dominik, it's great to see you.
It's such a pleasure to be here, Tamara.
My glasses are fogging up if you're watching on YouTube because it's really hot out and very steamy in here. Today we're going to talk about social prescribing, which is something I think that a lot of us do, but I've never really heard of the term. Can you explain what social prescribing is?
Absolutely. If you think of a regular prescription, let's say you go to your family doctor's office and you get a regular prescription, it's for a medical need, right? Social prescriptions are very similar. They're prescriptions for social needs. So I think of anything like good nutrition, income supports, housing, these basics that influence health and we know contribute a large part of health and well-being, all the way to things like social purpose, connectedness with our community, giving back, these things that we know impact how we do in terms of our own health and also impact how long we live and how healthy we live.
Okay, so social prescribing isn't coming from your friends.
No, not quite. It's oftentimes from a systems navigator or let's say your family doctor or primary care professional where they'd recognize a social need that impacts your health, your medical health, and then they'd go ahead to connect you with resources or supports or even groups in your community that would be able to navigate that for you. But, Tamara, it's a really good question because you could think about where is this ideally situated? And ideally, being in the medical system and addressing social needs is way too far downstream, right? You could see how ideally this would be through community centers, workplaces, places that are actually much more accessible to people than necessarily the medical system.
Because I'm thinking so many people in this country don't have a family doctor.
Yeah, absolutely.
They go to a walk-in clinic or an urgent care place and they, you're in and out, right? It's like for lack of a better description, it's just like a factory, right? I think we get 10 minutes with our GP if we have an issue or something like that.
Yeah.
So how does that work? Like, how do we get to a place where we can go to our family doctor and have a conversation and then they can, help us with social prescribing, if you will?
Yeah, the first step is actually just to have a family doctor or a primary care professional and have that relationship on an ongoing basis. Because if you think of what it means to get good medical care and what it means to get good social care as well, it's really based on the relationship, based on a shared understanding of where you're coming from, what your health history is, what your social needs are as well, what your strengths are too, what your current supports are, and what's your family situation, where you're at in your community, what kind of things you're already plugged into. So it's really important to invest in that relationship, kind of like a good insurance policy where you invest in seeing the same clinician over and over, invest in that relationship, even when you're reasonably healthy, so that when you need it, whether it's for a medical need or to navigate some kind of a social need, you're able to do it.
So what about people who are listening who don't have a GP? They don't have a family doctor. They can't find one. I have friends all the time saying, hey, is your doctor taking new patients? Yeah. And my doctor isn't and hasn't been for years.
Yeah, it's really unfortunate. And we know in Canada, millions of people don't have a family doctor, unfortunately, right? Even in my province of Ontario, it's over 1 million. But we know that having a family doc or having a primary care professional adds years to life, right? It actually increases your lifespan, and it's associated with longer life, better preventive care, fewer visits to the hospital, fewer visits to the emergency room. It keeps people healthy at the end of the day. So I'd say if you don't have a family doc, try to connect in with one, have some kind of a trusted entry point to the healthcare system. It's not ideal to be kind of seeing a different person each time you need care. You really benefit from having that trusted relationship with someone who knows you, understands your values, and at the end of the day also understands your medical history and where you could really co-design what it means to stay healthy, whether it's from medical needs or what we call kind of social needs and social prescribing in that venue.
Is there a way to have social prescribing, like you mentioned, community centers and all, I'm just trying to think, like, how do we service the millions of people that don't have a GP? Like, do we need millions of GPs in Canada? Do we need to attract, you know what I mean? Like, I'm trying to think, 1 million people in Ontario without a GP is a lot of people. I don't know what the number is in other provinces or in the province where I live in BC. I know it's a lot of people. I'm sure it's around the same, but so how do we need to attract more people to be family doctors, or do we need to come up with a different system to create these relationships with people and their primary care doctors?
Yeah, I think it's more the second one. And on top of coming up with a system to really build those relationships, it's about supporting the family docs and primary care professionals we do have. I think of this wonderful example coming out of the United Kingdom and the NHS, where they actually committed a few years ago to building out link workers, as they call it, throughout their health service, where family doctors, or GPs as they're called in the United Kingdom, are able to actually identify a social need, because they often actually come up naturally when let's say you're treating someone for diabetes or mental health, and you see that they need affordable childcare, as an example, or housing, or income supports, or good nutrition, or they're socially isolated, and so forth and so forth. They come out during the regular course of a visit, but it takes a long time to actually delve into that. So the NHS said, let's plug in link workers, specialists in a person's community in every single primary care practice, so that we have a referral that family doctors, primary care professionals can make to explore this, to build out that relationship, and to see what kind of social needs we can fill based on that.
Yeah, that's really interesting, because I know a few GPs, and they are all, and I'm sure you experience this too, they're all overworked, and they have more patients than they could. It's outrageous, really. So I know, I have a friend, David, he's in his 70s, he's a GP, he's been trying to retire for years and years, and he's officially retired. Very hard to find someone to take over his practice even. And he's just continuing to see his palliative patients. Do you think this is now becoming the norm, like for GPs, that they can't even retire because they're so scared to leave their patients because there's no one there to take the load, And I love to think of solutions, right? And I'm sure that in your world, you're always thinking about what are the solutions so we can see more people, we can be more effective at what we do.
I totally acknowledge the sentiment that in terms of not being able to even step away. So even not to mention retirement, even just taking time off. If you're a family member or sick, or you need a well-deserved rest after this blizzard really that the last year and a half has been. We need to make sure that we have systems in place to support health professionals more broadly, including family doctors. They're a key part of the health system, to actually be able to first of all take care of their patients effectively and their communities effectively, which includes maybe outsourcing some of these conversations to folks like link workers who could build those relationships as well and navigate kind of the social system. That's actually a load off of my plate if I have a link worker connected to my practice. But then also there's this sense of how do we support health professionals from a human resources perspective, recognizing that we're humans too. We get tired too. There's I think a crisis of burnout coming out, especially in the last year and a half, especially in our carers and essential workers like health professionals. So how are we caring for our carers? I think that's a really key question as we think through what's our future looking like post-COVID, especially in this time of really a tough month and a half, especially in the day-to-day work of healthcare and caring for people.
Yeah, I think you really hit it there, didn't you? And I think that it's something that the average person, and when I say average person, I mean myself, we don't think about, right? It's like, I know that if I'm sick, I can go to the hospital and somebody's going to look after me. Yeah. Right? But who is that person? And what have they been doing the last 18 months at the hospital? during this pandemic, right? They've been working and raising their own families. And we sometimes forget that healthcare workers, our family doctors, our, surgeons, they're people too with families and responsibilities. So I love the idea of the link worker. So tell me, in the UK, would a link worker, what would their background be? Are they a physician? Are they a medical expert in some way?
Yeah, I'll share with you the experience I have in Canada with link workers. And I trained Tamara at McMaster University in Hamilton. Hamilton is a city with a ton of health disparities, even despite having a world-class medical institution, medical system based out of McMaster. And I think a lot of other Canadian cities can relate to that, right? Where you see these disparities, even walking from one neighborhood to the next. And you see how these disparities can impact health quite a bit. We know that 80% of health and well-being is related to those social determinants and not just your biology and genetics. So at McMaster, when I was training, going through family practice specialization there, we actually had the pleasure of working with what's called a systems navigator. Would be a social worker who'd understand the social systems, different types of income supports, but also programs around smoking cessation, exercise, nutrition, even things like municipally subsidized childcare for folks. And if I was able to recognize a social need in a person that I was caring for or in their family, I was actually able to refer out. The systems navigator name was Dan Edwards. He's absolutely phenomenal. And we actually learned a lot as family doctors to be, and as people who were specialized in primary care and family medicine, going through this kind of a system of how to interact with our patients, how to address social needs, how to think through, what's not just what's wrong with this person in a health perspective, but what matters to them. What matters to them health-wise? What kind of things could we do beyond just the medical prescriptions to help in terms of their health?
Mm-hmm. Yeah, I mean, it just seems to make so much sense. Everything you're saying, why aren't we doing this everywhere? And, but how do you organize something like this, Dominik? How do you, if I work for a big company, I have a human resources department and I have a VP of this and I have when you are a group of physicians, family physicians in, say, Ontario, do you have do you have one person who decides what you're going to do or how you're going to, make this idea work?
I like to think of primary care and family medicine in Canada and in Ontario as a sky of stars, right? Where you have stars that are, shining bright, working very hard, really caring and really contributing to their communities. And then you have some constellations, right? That may be groups of docs, groups of health professionals and folks that are connected in with each other. But what's really missing is that kind of that galaxy that's bringing everything together. That's maybe saying, you know what, in these areas, in these neighborhoods, we could really use some more supports for social needs, or something like a link worker or a systems navigator that's plugged into family practices, or this lens of health promotion where it's not just within the medical system that we can address health and social needs. It's actually much more upstream, community centers, schools, and so forth. So I think that's what's missing, this galaxy approach, this sky of the stars. Even though the stars are burning bright, we don't really have the interstitium or the in-between. Mm-hmm. Just like an organization would have an HR or even a strategy department or something of this sort.
Yeah, it seems to be an important piece missing. Something you just said made me reflect on when I went to elementary school a long time ago. We always had a school nurse, mm-hmm. right? And so you would go to the school nurse if you hurt your ankle, or I had one in high school too, or if you were having a hard time with something. And, you could go to the school nurse and talk to them. We don't have that access anymore, with cuts and do we need to head back to that sort of idea of supporting people from a young age in schools? Because you can't always a lot of kids don't have family doctors either. Do you think that that's a piece of the puzzle too?
It's a brilliant idea, and what a school connection to the health system would do is, one, normalize seeking care, two, normalize having health conversations, including these really tough topics as our kiddos grow up, like mental health or healthy relationships and sexuality. And the list goes on and on. So I think that's a phenomenal idea. And it also speaks to addressing the social needs within healthcare. We know that especially for things that are ongoing, right, like diabetes and other diseases that are not just lasting for a few days or a few weeks, as well as mental health, things that are more sensitive, having that relationship into the health system and having that relationship that could also navigate some of the social care system for you makes a huge difference for folks.
Yeah, I mean, as we talk about it it just makes sense. Like we should go back to the way we used to do some things, and then we should, there's some new things that we need to try moving forward too, because I especially Dominik, when you just mentioned mental health, and this last year and a half has been incredibly difficult for most people, I would say, and for varying, reasons. And we don't all have access to a counselor or a therapist or a psychiatrist or a psychologist because of money, or there are none. They're all full. You can't get in to see somebody. So would social prescribing, how would it help somebody who is struggling with their mental health?
Yeah, if you think of the roots of mental health challenges, and when people experience, let's say, anxiety or depression, some of it is biological, some of it is related to their classic medical perspective, right, genetics and so forth. But actually, a large part of it is that social piece, right? Social isolation, loneliness, sometimes things like poverty or job insecurity, and the list goes on. You think of the topics that we're just coming to terms with right now and just starting to address as a country and as a global as global citizens, like race and racism and the history of injustices, including in Canada, that are that in our past and also ongoing. If you think of all of those things that contribute to someone's mental health, it's not surprising that the studies we have on social prescribing to date show actually a really impressive improvement in health, well-being, social connectedness, and we'll have to do more of those to see how that impacts things like diabetes, heart attacks, and so forth. We probably know it does, but it's easy to see how, and it's because of that 80% of health and well-being being linked to those social factors like income, housing, nutrition, race and racism, and so forth and so forth.
We use the word privileged a lot these days because you see it everywhere, and I think you really see it in healthcare, right?
Yeah,
because
absolutely.
You are privileged if you have a GP or a family doctor, because as we mentioned at the beginning of this conversation, there are millions of people in this country that don't have access to that. Many of those people live in poverty and isolation, and they just don't have access to it. We do have things now like telehealth, and where you can talk to a doctor online. Do you think the pandemic has really helped us, push that forward, right? We were always experiencing it, but not to the degree we are now, right? Partially,
we've maybe made a dent for communities that are underserved through the pandemic in terms of access. Maybe the thing that really stuck with me from my training in Hamilton was actually something called the Code Red series. Have you heard of this, Tamara?
No.
Yeah, it's a brilliant piece of reporting where the Hamilton Spectator, which is the newspaper for the city, actually looked at which communities have the most ER visits, have the worst kind of maternal mortality and other health outcomes, have the lowest life expectancies, and all of these different health-related topics. And then they also looked at where those social determinants of health were. What's the income status for that community? And they found that actually people with the communities that had the lowest income also had the fewest family doctors. They had the most emergency room visits. They had the most hospitalizations, and actually by quite a bit the lowest life expectancy as well. So I think we're starting to tackle that, because this conversation is not new. We've been talking about the social determinants for a long time. It's time we do something about it. The interesting thing is that they actually did a part 2 of the Code Red series a few years ago. And what they found was, despite all this work in uncovering the social determinants, things actually got worse since the original study many years ago now. So I think it's, I'm not sure what it will look like after COVID. I think probably the disparities have just widened. We know that this is not just a biological disease, it's a social, economic type of disease that impacts people disproportionately. And I think we really need to commit as health professionals, as health systems, as governments, and as a society as well, to look at how are we keeping people healthy? How are we bridging that gap between the healthcare and the health that people who are underserved by the health system and social care and everything like that receive, and then everyone else has in terms of those outcomes.
Yeah, some really good points, Dominik. Okay, so we, I know you know this, but on this program, we like to give back. And so as a thank you to you for spending some time with us, we are going to give Covenant House Toronto $500 on, to them from you on your behalf. We have a Covenant House here in Vancouver too. I'm very familiar with their work. Why did you choose Covenant House Toronto to receive the $500?
Covenant House is one of these organizations that I would call addressing social needs. And they're one of many, especially in places like Toronto and Vancouver or Hamilton, that have these really wide health disparities for folks. So Covenant House just happens to address food security, housing, right, giving people a home, a sense of purpose, many other things for youth. I know that youth have been especially hard hit from the pandemic. And I know from personal examples in many of my patients how much of a difference this organization makes. So I thought it would be a really helpful contribution to the organization there.
Oh, well, thank you. Thank you for choosing them. And we will be giving them $500 in your name. So, Dominik, as we're wrapping up, who do you look to? Like, what other countries do you look at and go, oh yeah, they're doing healthcare right. They're handling this good. They're doing, a great job. We should aspire to be more like them, because we do hold, as Canadians, we hold our healthcare system up in the air and we're like, look at us. We're amazing. We're so amazing. Are we amazing?
We have a long way to go. So if you think of our healthcare system, there's a part of it that's covered, but then a large part actually isn't. So you think of medications, glasses, vision care, how basic is that? Things like dental care and so forth and so forth. There are many, many things that people really need that aren't covered. Canadian healthcare system, it's a problem. I think that the group that I'd point to actually is closer to home than internationally. There's an organization called the Alliance for Healthier Communities, based out of Ontario, that's actually done some remarkable work in both social prescribing and then also thinking through how do we address social needs in our local communities to make health better in a more comprehensive way than I think the regular health system is used to. And I believe that we could look to organizations like the Alliance for Healthier Communities to shape what we want our health system to look like after COVID and beyond.
Okay. And so if someone's listening and they want to help, not a physician, not a healthcare worker, but they want to help and they want to, be a part of this change, because I agree. We do need some change. We need to move forward in many ways when it comes to our healthcare. How can someone get involved to help?
is the call to action, right?
Yes.
So I think the big one is to start asking why when you see things that don't make sense. And especially in the healthcare system, we know that there are many things that really make no sense in healthcare, like, let's say your clinician visit being covered, but then your medication isn't. How's that fair? But let's say your visit to an eye specialist not being covered. How's that fair? Or a dental and an oral specialist. How's that fair as well? Or long-term care and retirement home. All of these things that are important for healthy aging. Too, there are large parts of it that aren't covered. So I think a big part of this is asking, when you see things that make no sense, why? Why is that the case? And then asking them of our decision makers too. So the people that are elected officials, holding them to account. If you can't find a family doctor in your community, reach out to your member of provincial parliament or whoever your local decision maker is, because that's really on them, right? And I think slowly we could start to make a change, make it so that we can more comprehensively and better support our carers on one hand, and then better care for Canadians on the other.
I love it. Thank you so much, Dominik. This is, it's always great to speak with you. I always learn something and I really appreciate it. You are on Twitter. Your Twitter handle is Dominik Nowak MD. That's what you are, right? Are you on Instagram too, or are you just on Twitter?
No, Instagram is too new for me.
Okay, well, next time I'll give you an Instagram lesson, okay?
I'll take you up on it.
Okay. Thanks so much, Dominik. Always great.
Tamara, pleasure to be here.
Thanks for listening to another episode of TELUS Talks with Tamara Taggart. Be sure to subscribe so you can join us every Tuesday for another conversation. You can also check out our website, telus.com/podcast, and subscribe to our YouTube channel at TELUS Talks.